This is Richard Semelka. I am going to show you today an extremely fascinating case, and I'm going to describe the findings as we go along so you actually see how I evaluate MRI of the abdomen, which is something that perhaps arguably I'm the world authority on. So, and some of these things I'm just going to have to jump through too quickly because I'm trying to illustrate to you a very complicated case. So we're looking at non-contrast T1 weighted images, and we see a number of lesions that are low signal intensity and well defined, scattered throughout the liver. Notice how maybe we're seeing about 10 lesions that are low signal intensity, well defined on non-contrast T1 weighted images. And in the right kidney, we see a very large mass, maybe it's about 8 centimeters in size, which abuts the psoas muscle, and this is the mass here. So the next I'm going to go to, I'm not going to show you out of phase, but critically, the out of phase does not show us fat or iron in the liver. Now this is looking at a T2 weighted sequence, and I want you to notice that again, maybe we're seeing a few more, but very well defined lesions which are high signal intensity on T2 weighted images, and perhaps we're seeing about 10 lesions at this time. And again, we see this large mass. You can see this sort of what we call beak sign from the lower pole of the right kidney, consistent with a renal origin. I want to draw your attention to the fact that it's very high signal intensity and irregular centrally. High signal intensity can reflect a number of things, and I'll show you shortly that this reflects lack of enhancement, which is consistent with necrosis. So the next set of images I'm going to show you are the non-contrast T1 weighted fat suppressed images. I want to draw your attention to the pancreas. This is the head of the pancreas, and the pancreas itself looks very good. This is the body of the pancreas coming across. Again, we're looking at these lesions in the liver, and on the non-contrast T1 weighted fat suppressed images, we see about 10 lesions. On the T2 weighted image, we saw about 15 lesions that were well defined in high signal intensity. And as we page through, we see the large mass arising from the right kidney. Now, the next set of images are what I call arterial dominant phase imaging with contrast in portal veins, and prior to contrast present in hepatic veins, which these are the hepatic veins right here, which is the most important set of images, and this tells us about the arterial flow to various lesions. Now we can see these lesions, and I want you to pay attention to the fact that they show largely very intense, extremely intense enhancement, the larger ones with some lack of central enhancement. But now suddenly we're seeing maybe additionally beyond the 10 to 15 we saw on non-contrast images, we're seeing about 20 images, 20 lesions, which show increased arterial enhancement. Pancreas, this is the best phase to look at the pancreas. And one of the things critical for us to look to make sure there isn't a pancreatic mass, because hypervascular metastases are very typical of pancreatic cancer, but we don't have to think about pancreatic cancer because we see a large enhancing mass in the lower pole of the right kidney, beak sign between this is the normal kidney, this is the tumor, with central necrosis. So the next set of images, now before we get to the next set, I want you to pay attention to the bowel. Now, most recently I've described a disorder which I think is the most common disease now in the US, which is splanchnic inflammatory syndrome, which is essentially inflammation of the splanchnic system that can be anything from as minor but significant to the patient as stress, all the way to the metabolic syndrome, which of course I prefer describing it as the splanchnic metabolic syndrome. So we see early on increased enhancement of the wall of the jejunum. Bowel should enhance about the same as muscle. This is the psoas muscle, this is the jejunum, this is the wall, shows increased enhancement. This is now the proximal duodenum. Now this level of enhancement almost approaches that of the aorta and certainly approaches the signal intensity of renal cortex. This is a normal left kidney, and I use kidneys as a reference point for enhancement. We're coming up more superiorly, looking at the stomach enhancement. It's a little bit heterogeneous, but doesn't look so impressive. This is the paging through. We see the proximal duodenum. This is duodenum right now. I would say that this is too intense enhancement. This is very similar to the aorta and very similar to the renal cortex. But notice that we see all this intense arterial enhancement now of many more lesions. And the ones that we're now seeing all measure less than centimeter, in fact, less than 5 millimeters. So the next important sequence now we're going to go to is what would be called the early venous phase. And we can see that the small little hypervascular lesions have all resolved, but notice how the bigger ones still retain contrast. This is quite an optimal one in the right lobe, and this another one. In fact, we see some central increased enhancement of these lesions. And we'll take a look again at the renal mass, and we can see that the renal mass shows central lack of enhancement. So now we know that this isn't just a high edema inside a solid tumor. This is central necrosis. So now the next, and in fact now I consider the critical data set for looking for splanchnic inflammatory syndrome, which is inflammation of the splanchnic system. And again, all those tiny hypervascular lesions are not apparent. They have what I call faded to background normal signal liver. This is not a fatty liver. This is an iron-containing liver. Didn't show you those images, but you'll have to take it on my word. So this is true fading to background normal liver, the small lesions, but the larger ones have still retained contrast. As you can see, the larger ones have retained contrast. I also want to draw your attention to the appearance. Now, this is the best images to look at the distal esophagus. Now, I would say that the distal esophagus is borderline, it's probably normal. As we come down looking at the stomach here, stomach, proximal duodenum, duodenal bulb, this enhancement is too much of the proximal duodenum. This enhancement of the jejunum, which we're seeing here, is too much at 5 minutes post-contrast, which is what I'm targeting as the important sequence to see splanchnic inflammatory syndrome. And notice that the renal tumor, which had enhanced quite intensely earlier, now a lot of it is now dark. I would call it washing out. But centrally, we see lack of enhancement. And again, we can see renal cortex and a beak sign because the masses are rising from the kidney. So we're going to summarize it this way. The liver lesions show high signal intensity on T2, the larger ones, smaller ones, iso-intense. There's increased arterial enhancement of the lesions, and they small lesions fade to isointensity, the larger lesions retain contrast. Now, a large mass in the kidney with central necrosis like that, beyond 5 centimeters in size, as I've written in my textbooks, we expect renal cancer to show that. If it doesn't show central necrosis, then we have to think of another lesion. So this did show central necrosis. It was well defined. So we would call this a renal cell cancer arising from the lower pole of the right kidney. The lesions in the liver are very interesting. Usually when you see many lesions and you have a primary cancer elsewhere, many lesions in the liver, you have to think of metastases. Now I want you to remember I said that the patient also has splanchnic inflammatory syndrome, and we're just starting to recognize the full extent of abnormalities with splanchnic inflammatory syndrome, but benign liver lesions are amongst them. Now, hypervascular metastases generally show intense arterial enhancement like these, show high signal intensity on T2 weight images like these, but they show either fading to background liver or at times washout, which is getting darker than liver, which these did not show. These showed retention of contrast. The smaller ones showed fading to background. So, in all of my experience of looking at the liver, there's 4 types of lesions that can cause high signal intensity on arterial phase images as large categories. 1, hepatocellular carcinoma and family members of it, such as high-grade dysplastic nodules. 2, hypervascular liver metastases. 3, hemangiomas. And 4, focal hypernodular focal nodular hyperplasia, and the family of hyperplastic liver lesions. The next point is high signal intensity on T2. What shows very high signal intensity in T2? Of them, only metastases and hemangiomas show high signal intensity on T2. So for the bigger lesions, we're crossing out hepatocellular carcinoma. We're also crossing out, for the bigger lesions, focal nodular hyperplasia. Now, intense arterial enhancement, as I said, we see in those 4 lesions: FNH, which is focal nodular hyperplasia, hemangioma, metastases, and HCC. But it didn't have high signal intensity on it didn't have high signal intensity on T2 for the small lesions, which can be seen in all of them when they're very small. But the high signal intensity of the larger lesions rules out FNHs and HCCs. Now, HCCs, when they're the size that we saw the bigger ones, they show washout. Always they show washout. So we cross out HCC as a possible cause. The next point is that metastases, hypervascular metastases, fade to isointensity with liver, or they can at times wash out, but they do not show retention of contrast, which these larger ones did. Now, you could imagine, well, how about extremely rare metastases that have a high fibrous tissue content? Well, that's possible. But generally speaking, the vast majority of hypervascular metastases fade to background or show some washout. These retain contrast. The small lesions, however, all faded to background. Now, small hypervascular lesions, not bright on T2, fade to background. Those are the appearance of focal nodular hyperplasia or the family of hyperplastic liver lesions. Metastases, as I said, the small ones can fade to background. The big ones, the they have to fade to background or wash out, and these didn't. HCCs, again, to reiterate, they should wash out the bigger ones. These did not. So that leaves us with the highest likelihood for the larger lesions being hemangiomas, but the enhancement's somewhat unusual. So maybe these are capillary hemangiomas or some hemangioma variant, like littoral cell angiomas, for instance. Now, the small multitude of tiny lesions may represent FNHs or family members of that category, various hyperplastic lesions. They could still be metastases, and they also could be HCCs. So the small lesions could be any of them, but overall, despite this large renal cancer, I'm favoring as a diagnosis hemangiomas for the larger lesions and focal nodular hyperplasia and hyperplastic lesions for the small ones. And how to explain all of these lesions? We explain it because the individual has the bowel findings of increased enhancement, which is consistent with the splanchnic inflammatory syndrome. What's unusual is she did not show fatty liver, which more or less is a classic combination of fatty liver with bowel enhancement, but she did show that there was presence of benign liver lesions, which are, there's limited ways that the liver can respond to inflammation, which, in my opinion, reflect the liver response to pan-splanchnic inflammatory changes that it has developed benign liver lesions. Thank you for your attention.